Hi, I'm Verghese Matthew, interventional cardiologist and professor of medicine at Mayo Clinic College of Medicine. I appreciate the chance to talk in advance of our upcoming article entitled Assessing the Risk of Aortic Valve Replacement for Severe Aortic Stenosis in the Transcatheter Valve Era. What we set out to investigate here is the management of patients with aortic stenosis. Up until a few years ago, the conventional treatment for aortic stenosis was primarily surgical. That is, patients would undergo a median sternotomy, be put on a cardiopulmonary bypass machine, and have their native valve excised and replaced with a bioprosthetic or a mechanical valve. Over the years, we've come to realize that many patients with severe symptomatic aortic stenosis were not offered surgery, primarily for concerns of their perceived operative risk and the question of whether they would glean substantial benefit in the long term. It's been reported that up to 50% of patients with severe aortic stenosis were not offered treatment in that regard. Over the last several years, we now have a catheter-based option for insertion of a bioprosthetic aortic valve, which can be done through the femoral artery, through a transapical approach or a transaortic approach. And this has been approved in patients that are at high risk for conventional surgical treatment or in patients that are deemed inoperable. This new treatment has given us an opportunity to think about how we stratify and assess patients for operative risk and how we select these patients moving forward. Conventionally speaking, many clinical parameters go into assessing a patient's risk, but oftentimes we may make a subjective determination as to whether or not the patient is at increased risk. Elderly patients with increased comorbidities may be perceived to be at higher risk for surgery. However, if we actually quantify their risk using a scoring system such as the Society of Thoracic Surgeons or STS score, we may quantify their risk as acceptable. If we translate these data to the patients, they may be able to better ascertain their willingness to embark upon an operation relative to their personal goals and desires. We've learned quite a bit about surgical aortic valve replacement, ironically, in this transcatheter valve era. In the studies comparing surgery to transcatheter aortic valve replacement, we've learned that if we indeed quantify surgical risk, that indeed many of these patients have acceptable risk for surgery and are willing to proceed. We've also realized that our surgeons do excellent work, and many ill patients who are elderly still get through surgery and garner long-term benefit. So the real issue then is determining how exactly to calculate risk in any given patient and how best to convey that information to a patient and their family. In determining operative risk, there are a number of clinical variables that we input into making that determination as to whether a patient is likely to do well with surgery or not. Some of these variables include the presence of cerebrovascular disease, prior stroke, lung disease, or kidney disease. Many of these things increase the risk of surgery, but most would say that if we think about these objectively, they don't prohibit surgery necessarily. So really when we're talking about risk, we're talking about a spectrum of operative risk and what we as providers are willing to recommend to patients and what patients are willing to accept from themselves with respect to the potential benefits, i.e. lengthened survival or better quality of life than they currently have with severe aortic stenosis. There are some patients that we deem inoperable. They may have clinical variables that make them so high risk that we believe them unlikely to benefit in the short or long term from an operative approach. Or they have anatomic issues such as prior chest radiation or thoracic deformity or a very hostile aorta that makes aortic valve replacement technically challenging. In reality, very few parameters make a patient absolutely inoperable on technical grounds, although this is a bit of a misnomer in the common understanding even amongst medical professionals. And what we hope to develop here in this manuscript is the fact that if we quantify risk, we are able to better ascertain a patient's likelihood of benefit in the short term. The other part of the equation here is, of course, ascertaining the long-term benefit or value of a procedure up front. When we think about operative risk, we generally think about surviving surgery or the first 30 days after the procedure as the milestone in terms of assessing that endpoint. However, patients are also interested in what quality of life and what they gain in the long term, whether it be survival or otherwise. And I think that's an important determination that isn't well quantified in our current risk scoring systems and needs further evaluation and understanding. So as providers, our main focus now is to, number one, better give a patient an impression of their short-term procedural risk in order to make a determination about surgery versus TAVR versus no treatment at all, for example. The second part of the equation is, what is the long-term value of that treatment? There are some people with important comorbidities that may not necessarily benefit in the long term because they're severely debilitated or life-limited by other medical problems besides the aortic stenosis. And obviously the important component here that we want to focus on is the patient, their loved ones, and their impressions on how best to assimilate this information to make an individualized decision that's right for them. So as we talk about these issues, we talk about a multidisciplinary approach to these patients, cardiologists, radiologists, cardiac surgeons, and others that partake in the care of these patients in order to make a unified recommendation of how best we should manage these patients. And then, of course, we want to involve the patient, their family, and other loved ones in terms of assessing their goals and putting their goals and the data that we have together in a manner best suited to their preferences. In the final analysis, what we've come to conclude is that patients with severe aortic stenosis do have varied treatment options now. Conventional therapy has been surgery, although patients at high risk for conventional surgery now have a catheter-based approach. The onus is on us moving forward in terms of assessing the risk and the relative value of each of these treatment options in conjunction with the patient's and family's wishes in terms of their goals.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.com. This video content is copyrighted by Mayo Foundation for Medical Education and Research.